Well, let's talk about obesity, because we know obesity contributes to beta cell damage, insulin resistance, and type 2 diabetes, further complicating the disease. We know that weight loss interventions can avert type 2 diabetes in pre-diabetic patients, may reduce the impact of diabetes on patients long term. Reducing obesity is considered a crucial part of diabetes care. We know that patients who lose 5 to 10% of their weight at 1 year can lower their glycosylated hemoglobin A1C levels by up to 1 percentage point, reducing their risk of complications and potentially reducing their need for type 2 diabetes medications. Lifestyle modification, and by that I mean weight loss, dietary changes, increased physical activity, it's recommended, but again, it is difficult for many patients to initiate. There's time, there's motivation, and there's all this stuff out there telling them to eat more and not necessarily better. Very difficult. Now, AHA, ACC, the Obesity Society, they've all issued guidelines defining obesity as a disease and recommending the use of chronic disease management tools. These approaches involve a multidisciplinary approach incorporating nurses, educators, pharmacists, physicians, and that has implications for clinicians and payers in terms of time and, of course, in terms of cost. So, Maria, what's been your experience with wellness programs and lifestyle modification programs for obese patients? Do they work?
They work for some, but I would say it's a very small minority, and often they don't work in a durable and sustainable manner. So it's difficult. I think it's challenging for patients. I think it's challenging for caregivers. I almost think obesity is where we were about 10 years ago with smoking cessation. And I do agree with you that we almost need a societal, much bigger societal campaign around obesity so that we can assist members, be much more successful with weight loss.
It's funny you mentioned that, because smoking is an addiction, right? Of course, nobody needs cigarettes. Eating is an addiction too. We need to eat, but do we need to eat this much?
Probably not. Just getting back to the previous question, as far as wellness programs, I would agree with Maria that, if you get patient buy-in, those are the patients that succeed. So it's really a matter of finding the right patients that will, enter a program and then really be vetted for their own health care and weight loss.
So we know that lifestyle works. You just said it, we know it works. There are plenty of studies out there, diabetes prevention program, near 60% reduction progression to diabetes just with lifestyle. The look ahead, another trial, reduction in the kidney problem, the eye problem. It really works, but they're expensive. Lifestyle modification are expensive. Providing the education, the ability to exercise, the right food choices, and so that's very expensive. That's not provided. So we do a study, we show it works, but then we go to the patient, you say, it works, now do it. Now the patient doesn't have the tools.
That's just not fair, is it, Jeffrey? You can't do that.
No, I think there are a lot of people, a lot of different stakeholders included in this, and we all have to work on the same page. And that's a part of the challenge right now. And so, there should be a systematic approach to obesity management, just like there is for diabetes and other things. The problem is, historically, we've not had a lot of good options. And part of the problem is who's going to pay for this.
The $64 trillion question.
Yeah, so if you look at benefits, most obesity approaches are excluded benefits. Now, from a clinician, pharmacist that works for a payer, it's a major disconnect, because we know the implications on other diseases and on outcomes. But what the problem is, you've got employers and other people who are looking at your insurance company for premiums. And if you're covering these drugs, the impact on the bottom line is huge. And so you're going to have negative adverse selection, and your premiums are going to be higher than somebody else. And so I agree that I think there needs to be a different approach to this, one of which is government, some kind of societal approach that evens the playing field, so that we're not adversely impacted from a budget perspective. But then our approach with patients need to be different.